Welcome to the GlycanTrigger Podcast Series. Over the course of 12 episodes, we will engage with experts in inflammatory bowel disease, patients, and other relevant specialists, delving into their work and exploring the challenges within the GlycanTrigger project.
Hello to everybody. Today marks the official launch of the GlycanTrigger Project Podcast Series. My name is Salomé Pinho and I'm the project coordinator of GlycanTrigger, a project funded by the European Union through the Horizon Europe Research and Innovation Actions, which was launched precisely this year in January. So the global aim of GlycanTrigger project is to understand the intricate interplay of factors that contribute to the transition from a healthy state to chronic inflammation in the gut. Specifically, this project delves into the changes in the gut mucosa glycome, which is the composition of glycans or sugar chains that are exposed at the surface of our gut. So throughout this podcast series, we'll engage in biannual discussions with experts in inflammatory bowel disease, patients, and other key stakeholders connected to the GlycanTrigger project. So today's discussion will be around prediction and prevention of inflammatory bowel disease. And to guide us through the discussion, I have the pleasure to have here today Dr. Joana Torres, which is a specialist, a gastroenterologist at Hospital Beatriz Ângelo and Hospital da Luz in Lisbon, in Portugal. Joana is a specialist in IBD, and also have the pleasure to have Dr. Luisa Avedano, which is the Chief Executive Officer of the European Federation of Crohn's and Colitis Association, an European organization committed to enhancing the lives of IBD patients, providing them with a stronger voice and increased visibility. So thank you, Joana and Luisa. Thanks for coming and for having accepted to be part of this first edition of the GlycanTrigger podcast. So we all know that IBD is a chronic and debilitating disease of the gastrointestinal tract that affects millions of people worldwide. So in 2019, there were about 5 million cases of IBD globally, and the incidence is apparently increasing. So it makes all sense to talk about IBD prediction and prevention. So in an informal way, as this will be a very informal conversation, and I would like to start by asking to Joana, where are we now in terms of IBD prediction and prevention, in terms of scientific, technological advances?
Thank you, Salomé. Hello, everyone. Hello, Luisa. It's a pleasure to participate in this podcast. So I agree with you that we are seeing a rising incidence and prevalence of inflammatory bowel disease. And there have been many advances in the field with novel therapies, novel monitoring tools, many new things happening in IBD that I think contributed to improve the quality of life for patients, but we still don't have a cure. And many patients still suffer from disability, many patients need surgery, and many patients need long life medication. So I do agree that we need to start to think in new strategies. And what we're discussing today is this possibility of potentially contributing to stop this rising incidence and acting before disease is diagnosed. So this idea of prediction and prevention has been going on for a while. And actually, to our colleagues in rheumatology and diabetes, they started many years ago, and I think we are kind of catching up on their steps. And so many years ago, people like Jean-Fred Colombel, Ken Croix-Theroux, have these ideas to start these large cohorts, looking at serum, for example, obtained before diagnosis, or following at-risk individuals such as the first-degree relatives. And so we are starting to see the results of these cohorts that were started many years ago. So indeed, I think there is positive news because through different projects, looking at biomarkers obtained in different samples before diagnosis, we are starting to get results on biomarkers that can help us potentially to predict who is going to develop disease. And so there's still a lot of work to be done. It's important for people to understand this because we don't have those biomarkers ready yet to be applied in clinical practice in at-risk individuals. There is, of course, a lot of need for validating the results, validating those biomarkers in different population, and really kind of trying to bring biomarkers from different samples, representing different biological processes together so that we can kind of try to develop these more kind of simple biomarkers to be used. But I think I'm really positive, very positive that we will get there. And so I think something that it's very important also for patients to understand is that by doing this type of work, trying to understand what's going on before disease is diagnosed, potentially, I think we have the perspective that we can understand better the processes that drive disease initiation. And I hope that through this, we can also develop better therapeutic targets and better treatments for treating also those patients with IBD.
Okay, that's very important. More or less in the same line of thinking, how do you see the impact of genetics? So, I mean, IBD is a multifactorial disease, right? So how do you see the impact of genetics in predicting individual susceptibility risk to IBD? And from another perspective, how environmental factors, such as diet or even lifestyle, can interact with genetic predisposition, defining a potential risk for IBD development?
Yeah. So that's a very good question. And I think something that many families really tried to search when we started to have the news on genetics in IBD. And so for sure, there needs to be a genetic predisposition, and some patients have more genetic risk than others. But overall, together, genetics alone are not able to predict IBD. Mm-hmm. So we know that something else needs to happen. And as you very well alluded to, there needs to be some potentially, I think, some information or some hits from the external environment, which can come from environmental exposures, such as smoking, diet, stress, exposure to pollutants, exposure to some toxicants that need to interact with that genetic predisposition. And our hypothesis is that it drives potentially changes in the microbiome, and that those changes interact with the internal mucosal immune system at the intestinal level, and it drives then disease initiation. So genetics alone, even in those with family risk, genetics alone does not seem to be very predictive. So we for sure need to enrich a predictive tool with other type of biomarkers outside or aside genetic biomarkers.
Mm-hmm. Okay, and from the patient's perspective, Luisa, how do IBD individuals and even patients and families see IBD prediction and prevention?
Hello, everyone. I'm really pleased to be involved, and I'm really pleased to have the chance to try to give you the point of view of patients and to share which can be the difficulties in understanding the topics, but also the potential that can come from involving patients in the exploration of these aspects. I have to say that in general, even due to the characteristic of the Crohn disease and ulcerative colitis, talking about preventive medicine and prevention or prediction is not very common. I mean, it's something that patients know, and particularly when it comes to looking at the family history of some patients, some elements are taken into consideration. But from one side, there are several conditions that about preventing health measures, such as Joana was already mentioning, quitting smoking, weight control, adequate diet, etc., that are already part of the normal approach to the disease. So these factors can really offer a proactive control and can be easily assumed by the patients and by the relatives. On the other hand, when it comes to the concept of targeted therapy, how can a patient be part of a more articulated path of prediction, it's still something that requires more attention. I think that from this point of view, what is really important is to involve the community and inform since the very beginning, so since the diagnosis of the disease. So in this way, patients can really feel protagonists of this, because for us, generally speaking, for the community of patients, there are still the main objective that is taking control of the disease. That is, if you want something that comes in parallel with the prevention aspects, factors, or the preventive ones. So it's important to find a good balance when it comes to deliver a clear message to patients.
Mm-hmm. And as a follow-up, so from a patient's perspective, and in an ideal scenario of having the strategies and the tools for IBD prevention, and talking about prevention, when choosing between invasive preventive therapies or dietary intervention for IBD prevention, what do you think is the patient perspective and wish?
Well, I think that the starting point should be the possibility of having the control of the disease as much as possible. And when it comes to invasive activities or actions, of course, there is not, such a big interest. But then again, what is important is trying to offer the full perspective, the full picture of the situation. So even accepting some more unusual practices can be acceptable. But again, it has to deal with a very well-structured set of information and messaging. What is often happening is that patients are not fully aware of what is around them and what is proposed to them. So I think that with a good communication flow and also a very accurate involvement of the patients in the process, many of the obstacles could be removed. But I really believe that it's important to offer the patient an holistic view of the disease and which can be the possible approaches. And it's very rare. You have also to consider that as EFCA, we are representing 46 different national associations. That means different access to treatments and to information as well, to access in general. So for us, it's important to find some common elements that could boost the interest and also give patients more hope. So in this way, it's even easier to find a way to communicate with them.
Okay.
Can I just add something on what Luisa said? We have worked with Luisa and EFCA to build a survey in different languages that I think we will be able, Luisa, correct me if I'm wrong, that we will be able to start distributing early next year.
Yeah.
And the point of this survey is exactly to try to get people's understanding, not patients regarding their family members, but also first-degree relatives on their understanding of what would be acceptable for them in terms of prediction, if this is something that they are interested, and what type of predictive test they would be willing to accept. And of course, as well, if there would be an intervention strategy for prevention, what they would accept. So maybe next year when we repeat this podcast, maybe we can have a more informed discussion about this topic, because hopefully, and I'm also taking the time to advertise this survey here, because hopefully people will reply and we will get their perspective. I fully agree with Luisa that we need to make this path together, because otherwise there's a danger that, we are not aligned in terms of what we think may be the strategy and what people that would be willing to have a strategy believe.
Yeah. So this is involving the community. And this question now is for both. So we know that IBD, it's quite an heterogeneous disease, right? Not only we have different diseases because Crohn's disease and ulcerative colitis are not the same disease, despite the fact they are, both called inflammatory bowel disease. They are actually different diseases clinically, but also in terms of the therapeutic management. So take in consideration even the heterogeneity of the disease, the fact that the disease is heterogeneous in presentation, in the phenotype, right? And in the severity, different disease courses, how these will make a challenge for implementing IBD preventive programs. So how can these challenges be addressed? In a global perspective, perhaps Joana, and going towards a more personalized preventive program, given the fact that we are dealing with very heterogeneous diseases, right?
Yeah, so I think it's still difficult to answer this question. We have there is this large study called the PREDICTS study, where serum obtained before diagnosis was analyzed. And we tried to have, partially to answer your question, where we looked into the biomarkers many years before diagnosis. And then we tried to see whether those biomarkers were different in those patients that presented with complicated Crohn's disease, disease strictures, versus those patients that did not have complicated Crohn's disease at the time of diagnosis. And so indeed, what we saw was that there seems to be different pathways coming many years before diagnosis. And so, of course, the problem is that for us to really kind of take a deep dive into this, we need information, right? And so from some cohorts, it's possible to obtain this information, like some phenotypic information on disease course or disease location. And so there is attempts to try to address this heterogeneity in presentation for sure. So we don't know if there's like a common pathway that comes many years before diagnosis, and for some reason it kind of diverges into this or that phenotype, or if those phenotypes are already kind of preset. And so potentially by looking at these biomarkers, we can try to understand which pathways are being targeted. And potentially this can help us to tailor interventions. But this is very conceptual. I think aside from this work in PREDICTS, we still have very little information. We are trying mainly to focus on Crohn's and UC, and we still have limited information on this molecular or on these different phenotypes and how this can be translated many years before diagnosis.
From my perspective, or in general, because for preparing this podcast, I have been talking a bit with some of our colleagues that are involved in the general brainstorming and that are part of our group of experts. We believe that, again, the general framework is still keeping the community informed. That is very, very important. You were mentioning, Salomé, that the disease course can be very different from patient to patient. And this, again, it's something that needs to be very well explained to patients, because there is a tendency, if you can get the control of your disease, even to forget that you have the disease. And I think it's quite understandable and quite human. But I think it's important to explain very clearly that there must be high risk or low risk categories of patients, and they both can work together to identify the crucial elements, the triggers, or what we are discussing about. It's clear that from the patient perspective, it's even more theoretical than for scientists, but I think that the two communities, the low risk ones and the high risk ones, have to be involved more or less at the same level, because I think it's important. It's also a question of keeping a cohesive support to the community of patients.
Mm-hmm. Okay, so as a wrap up, I think just to mention that EFCA and Joana Torres from Hospital da Luz are both partners of the GlycanTrigger project. So we are all committed to this topic of IBD prediction and prevention. And as a wrap up, biomarker to define risk, so who will develop, who has the risk to develop inflammatory bowel disease, preventing and intercepting this house to intestine inflammation transition, and the personalized or individualized approach towards prediction, but also towards prevention, is a common denominator of GlycanTrigger project through this concept of gut mucosa glycosylation alterations. And I think we can finish this first podcast by saying that IBD prediction and prevention is a hot topic. It's very desired from the patient's perspective, from the medical community, but also from the scientific point of view. It's very important to design, first to identify the mechanisms underlying this health to intestinal inflammation transition, and having the knowledge of the mechanism, we can then better define these biomarkers for prediction, and also the best strategies for an individualized preventive approach. So thank you very much, Joana. Thank you very much, Luisa. And we keep on going with the GlycanTrigger project. And I mean, the 2024 will be an exciting year with many scientific discoveries, I hope, within this IBD prediction and prevention. So thank you very much.